Hello friends, recently we have started new sections on our channel. For instance, Sunday 5 Physiology Live. Let's deep dive into the concepts of physiology. Apart from that, the graph related discussions, the MCQ based discussions and many more. So it will be a good idea to subscribe to the channel and hit the bell icon. Now let's see today's MCQ. This week we had posted this MCQ, which is a hypothetical one, but the concept needs to be understood. A patient is admitted in the ICU and his blood pressure is being measured by two methods simultaneously. One, by intravascular catheter, which is connected to a manometer, and by sphygmomanometry, which is an indirect method of BP measurement. So the question was, sphygmomanometer reading will be what? How much? Will it be the same as directly measured intravascular pressure? Will it be higher? Will it be lower? Or depends on the blood flow. So you want to answer that? Well, the answer is sphygmomanometry will give you a higher reading compared to directly measured intravascular pressure. Let's understand the reason behind it. Here is let's say a brachial artery, and catheter was introduced into the brachial artery, directly connected to the manometer, and we are measuring the intravascular pressure. So whatever is the pressure, we are getting it directly as such, and then BP curve is applied and we are measuring it by the sphygmomanometry. By the intravascular catheter, we are getting the exact pressure which is actually present there inside the vessel. That's point number one. But by sphygmomanometry, we will get a higher pressure than the one which was measured by intravascular catheter. Let's understand the principle of sphygmomanometry. The principle is balancing of pressure between the cuff and the brachial artery, which means, let's say brachial artery has a certain pressure. Let's say 100 mm of Hg, some arbitrary figure. So balancing of pressure means we raise the pressure in the BP curve, and the idea is that suppose arterial pressure is 100, then when the outside pressure is greater than 100, the artery closes. So no pulse, no blood flow. And when the external pressure is just about 100 or less, the artery will open up for the first time and there will be a blood flow and the pulse. So we are having a procedure where we raise the cuff pressure. Let's say we have taken it up to 150 mm of Hg. Now obviously the brachial artery is closed because outside pressure is more than the arterial pressure, and now we start lowering the cuff pressure. 140, 130, 120, 110, 105, 102, like that. We lower the pressure, and we are now, so far the artery was closed, and we are looking for that point where artery opens up for the first time and pulse appears. In the case of palpatory method, we just check the pulse, and pulse appeared for the first time. We look into the manometer that time, connected to the sphygmomanometer, connected to the cuff. And that point where the pulse appeared for the first time, we take that point as the pressure, systolic pressure in the artery. Why is that? Because we assume that that time the pressure outside the artery or the cuff pressure was just less than the artery pressure. So we take that as the systolic pressure. But here lies the catch. Actually, there is a funda called as dissipation of cuff pressure. That is, let's say when the cuff pressure is 105 mm of Hg, about 5 mm of Hg out of that 105 will be dissipated in the intervening tissue. Look, cuff is applied to the outside, externally, and the artery is deep within. And between the cuff and the artery, there is some tissue, particularly muscle and fat. So cuff pressure, as it is reaching the artery, some of it is getting dissipated. By that I mean, if the cuff pressure is 105, actually 100 is reaching the artery. So imagine this, we are looking at the mercury manometer, it is showing us 105, but actually just outside the artery 100 has reached, and now the artery is going to open up for the first time and we feel the pulse. So we felt the pulse when the mercury manometer was showing us 105, and we take the pressure as 105, but actually the pressure is 100 because some of it got dissipated, some of the cuff pressure got dissipated in the intervening tissue. So what are we marking as the pressure? 105 mm of Hg, because that was the point when pulse reappeared for the first time. But actually what is the intra-arterial pressure, intravascular pressure? It is 100. So if you are measuring the pressure by intravascular catheter, it is giving you 100 mm of Hg, and at the same time, in the same person, at the same moment, the sphygmomanometry is giving you 105 mm of Hg. So it is giving us higher pressure. Now please understand here is that we are not saying that sphygmomanometry gives us higher pressure readings. No. By default it is giving us hypertension. No, we are not saying that for a moment. What we are saying is, just compared to the intra-arterially measured pressure, directly measured pressure, sphygmomanometry is giving us higher pressure. But all the data of blood pressure regarding the normal BP or hypertension, all that data is based on the sphygmomanometry, and therefore we are not getting any error by measuring the blood pressure by sphygmomanometry. Let that be very clear in your mind. This is not an error. All the data is standardized by sphygmomanometry. So we are not getting error like this. Just we are saying that compared to actual intra-arterial pressure measured directly by sphygmomanometry, we get a slightly higher pressure because of the funda of dissipation of cuff pressure in the intervening tissue. Now that being said, let's see a few more scenarios. For instance, what do you think will happen in obesity by this very principle? If we are measuring a pressure by intra-arterial catheter and by sphygmomanometry in an obese individual, what will happen? Obesity means more tissue. More tissue means more dissipation of cuff pressure. Yes, you got it right. If there is a more tissue, that means there will be a greater dissipation of pressure from the cuff to just outside the artery. So now in the obese individual, we will require, let's say, 106 or 107 mm of Hg, because now 7 mm of Hg will be dissipated because of his obesity, and therefore 100 will reach the artery. So in obesity, if we perform this same very experiment by sphygmomanometry, we will get even higher reading due to the extra tissue and therefore extra dissipation of pressure. What do you think will happen in atherosclerosis? Same principle, but let's not mix up the issues. Atherosclerosis already leads to hypertension, high blood pressure. That is a genuine correct reading of high blood pressure, and it is caused by the decreased compliance of the arteries. So atherosclerosis is going to have higher pressure in the first place. Plus, if we are performing this same experiment, intra-arterial catheter and sphygmomanometry, again in atherosclerosis, just like in obesity, it will give us even higher reading by sphygmomanometry, I beg your pardon, because atherosclerotic vessel means again an extra tissue mass in the vessel wall in the form of that atherosclerotic plaque, and therefore we will require slightly extra or higher pressure to occlude the vessel completely, and then therefore in that case also sphygmomanometry will give a higher reading, a slightly even higher reading. It means in a normal individual pressure is 100 and we are getting by sphygmomanometry we are getting 105. Then in atherosclerosis we will get 106 or 107 because of that atherosclerotic plaque, which will take some extra pressure for the artery to be occluded completely. Finally, what will happen if we are using small cuff? Let's say we are using pediatric cuff or smaller cuff. What will be the error? Now this time it is going to be an error by sphygmomanometry. Yes, error meaning, look, small cuff tends to occlude the artery incompletely. Because it's a smaller sized cuff, it occludes the artery incompletely. And therefore, in order to occlude the artery completely, we need to raise the pressure further in the mercury manometer. And therefore, when we are using small cuff, we get erroneously high blood pressure. This time it is an error in the technique itself. So therefore, these are some of the possibilities or possible errors in the BP measurement by sphygmomanometry. More such MCQs and more such conceptual discussions will continue, and I invite you all for Sunday 5 Physiology Live deep dive into the concepts. Thank you.